Hi, I'm Dr. Ashley Fuller.
And I'm Dr. Meredith McClure.
And this is Labia Logic,
the podcast that's all vulva, no filter.
We're here to talk about all the stuff your doctor rushed through, the questions you've been too embarrassed to ask, and the sex ed that barely mentioned the vulva.
Because too many people are suffering in silence with painful sex, menopause misery, and vulvar issues no one talks about.
No shame, no stigma, just real talk, real answers, and the education you should have gotten in the first place.
Welcome back to Labia Logic. I'm Dr. Meredith McClure, and with me as always is my best friend in vulva, Dr. Ashley Fuller. And we're here today to talk about something that's very common. A lot of people are a little shameful about it, but it is so common, and that is herpes. And herpes does happen, and that's the title of our episode today is Herpes Happens.
Herpes Happens. What I love about Labia Logic is that we've gone this year from like really exciting ones about orgasm, and it's so interesting, and now we're going to talk about herpes. So if you're here to talk about herpes with us, it's so awesome because herpes is super common, and as Meredith said, herpes happens.
Sure does.
And I wish there was so much less shame around it. In private practice, my nurse said to me, I'll make a lot of the result phone calls, but you always have to call for cancer and herpes.
That's fair.
And I was like, oh my gosh. I mean, I get it. Like, it's such a hard diagnosis to get. And, but really at the end of the day, and I'm not trying to downplay the shame because I understand, but like it is a skin sore, but there's so much stigma around it. And it's so common. Like so many people have it, but there's so much shame. I've seen people, you know, I'm sure we'll talk about this more during this episode, but people just ruining relationships and dating lives and ruining lives almost.
I have seen it ruin many relationships.
All right. Well, we won't jump into that stuff. Right? Let's ease our way into the badness of it.
What is it?
Yeah, what is herpes? Okay, herpes is a virus, okay? And I think herpes as a microbiology geek is actually a really fascinating virus because herpes, once you've been exposed to it, it lives in your nerve endings. So I always think of it like this, like you've been exposed to it lives in your nerve endings, and every day your immune system is fighting it off. So your immune system is keeping it in those nerves. And then some days when your immune system is busy, like, oh my gosh, I have to go somewhere else. There is a cold virus trying to make you sick. Then it leaves the nerve and then you get an outbreak. It's a, cursory way of thinking about it, but it is kind of what happens where it just lives in that nerve and it's always there. And because it's in that nerve ending, we don't have a lot of good, we're trying to get vaccines for it and different antivirals, and it's just really hard to treat because it's like it really evades our immune system quite a bit.
Yeah, it's a very sneaky, opportunistic virus, I would like to say.
It can be in your mouth or like on your lips or on your genitals. People with penises and people with vulvas can all get it. You can get it other places. Sometimes people get it in their eyes. You can get it other places. But generally, it likes that tissue that's on the edge, like that modified mucosal membrane of like lips and labia, things on penises. Well, I won't go too far down that path. And so there's different types. There's type 1 and type 2, and they're different. Type 1 is generally around your mouth, on your lips is what cold sores are. Type 2 is generally on your genitals, but not always.
Yeah, generally.
Generally genital.
So that's the way we were taught in medical school. One was up high and 2 was down low, but that is now not totally the case.
We definitely see patients who will get type 1 on their genitals. And I always say, well, if you're going to have herpes, like type 1 is better to get because you actually will get less recurrences, you have less shedding, and your outbreaks tend to be less painful if you have type 1. Type 2 tends to be more recurrences and more painful. What happens when you get herpes, usually your primary outbreak is the most painful one that you have. Meredith, have you seen some patients with terrible primary outbreaks?
It's one of the worst things I've ever seen, to be honest. Like, where you and I trained at the county hospital here in Dallas, like we had our own emergency room for gynecologic problems. And you knew when somebody walked in with one of those, it was either a vulva abscess or a herpes outbreak because they can't walk and they're febrile. I mean, some of the highest fevers I've seen, and their lymph nodes can be enlarged in their groin and they can't urinate. Maybe they're coming because they can't empty their bladder. Like you have to sit in the bathtub just to pee. Like it's awful. And then of course the ulcers that are on their genitals are extremely painful.
I vividly remember a 16-year-old girl with ulcers all over her vulva, couldn't pee, had to have a catheter put in, had to be admitted for pain control. I mean, some of these can be terrible. Tends to not be as bad for immunocompetent people, so people with normal immune systems, but for people who have issues with their immune system, sometimes it can be really terrible. And even in people with normal immune systems, occasionally it can be really terrible.
I've even seen primaries in postpartum patients and pregnancy, like their immune system is not great.
So generally when these start, they're going to start as a little blister, and usually people will have some kind of prodromal type of feeling, like little itching or burning or irritation, and then they'll get a blister. That blister usually lasts a couple days, and then that blister will break open and create a little bit of an ulcer. So they start with vesicles, we call them, or little blisters, and then that turns into a little ulcer, and then they will, a couple days later, they will scab over. So there's kind of 3 different ways they can look. It takes quite a while for them to go completely away after people have these sores for a week or more.
Yeah. And it hurts. Like there's ulcers and things you can get on the genitals that will not hurt.
Right.
Syphilis being one of them, but herpes will hurt. And that's kind of one of our clues is this is painful. and then if it's an ulcer, your herpes is going to be number 1 on your differential.
It's important to think where on the vulva people get these. It's often on the labia minora, around the perineum. Sometimes you can see them on the labia majora. I don't feel like I see it there as often, but it's usually on that inner labia. I often will see them on people's buttocks. So I think it's kind of from like that spooning positioning that can happen. People will get them like on their butt cheeks. And I think that's how that happens. I've seen that several times.
Maybe your little spoon.
When the person I'm taking care of is a little spoon, right? Yes.
Yeah, exactly. And aside, which also can be in the differential in this part of the body, is shingles. You can see shingles down there. And, you, the microbiology nerd, and talking about, herpes being so fascinating, how it goes in and stays in your nerve endings. So does the chicken pox. And these 2 viruses are fairly similar in their genetic makeup, if you will, because viruses are a little more complex. And so the chicken pox will lie dormant in the nerve roots. And these are just in your spinal cord. You have big fat nerves that kind of branch out all the way into your skin with many, many different tributaries from them. And the shingles will go in this nerve root, and it only stays on one side of your body. It's pretty fascinating. You'll have the ulcers just on one side. It will not cross the midline, but it can happen in the genitals as well.
It always follows a dermatome or an area of the nerve path.
Yes.
So how do you get herpes?
That's always the big question of patients. How did this happen? When did this happen?
Yeah.
That can be a really hard thing to answer, I feel. Because it could have been something fairly recent, and it also could have been something fairly long ago.
We're going to talk about testing in a little bit, but I think what's so complicated about this is like you don't always get the outbreak right when you've been exposed. It sometimes can live in those nerve endings for a while. Your immune system might fight it off for a little while. So the timing of when you get your outbreak is not always linked to when you were exposed.
Yeah. Because these are things that people want to know who, how, when. And this is a really hard conversation because a lot of it we won't know.
Right. But basically, it's skin-to-skin contact, genital-to-genital, oral-to-genital, or oral-to-oral. And so you don't have to have visible lesions to pass it. I think that's what's hard is that there is this high idea, we call it asymptomatic shedding, which just means that even though you don't have a sore, you could be spreading or having virus like on your skin that could spread to somebody else and cause them to be exposed. And then that virus lives in their nerve endings. And asymptomatic shedding is somewhat intermittent. Like, we don't really understand why it happens or when it happens, but it's like, even with no symptoms, you can still be like shedding virus and being able to pass it on to somebody else.
I think that's something that's hard for people to understand. COVID is, crappy as all of that was, I think it helped people to understand viruses a little better. And I would explain to people like, you feel like crap and you put that swab in your nose and it's not positive, and you could not have the virus present at the moment, but it's taking a minute for it to be there. These viruses are they're sneaky. You can have symptoms in there and the virus is there, or it's not really detectable on a test, or vice versa, and not have symptoms and the virus is there.
Yeah, I mean, sometimes you need a certain level to be able to be detected by the test, things like that. But yeah, any kind of skin contact, I mean, even sometimes like you can get it on parts of your face. People will get it around their eyes. Kids can get it if they're like adult kisses them. We talk a lot about babies and when newborns don't have much of an immune system, having older relatives coming over, like don't let them kiss the baby in case they could spread this. I mean, those kinds of things.
Even like sports, like wrestlers, you're in contact with other people and you come into contact with the virus, like it can happen wherever you came into contact with it.
Yeah. We didn't talk about incidence. We mentioned how common it is, but we didn't really give any numbers. But the WHO estimates about 846 million people, which is a lot of people. Between 15 and 49 are living with genital herpes in the world. Obviously, it's more than just the US. And there's about 42 million new genital infections per year. So it is a good number of people. This is not a rare virus. This is actually really, really common. I just wish there was less stigma around it because it is so common.
We see it a lot.
I'm going to jump in and say this. I had a patient earlier this week who came in with vulvar pain and her pain sensation was burning. And the first doctor she saw, who was not a gynecologist, basically tested her did a blood test and it was positive for HSV-1, which we're going to talk about blood tests in a minute, and said, oh, your vulvar pain is herpes. And she never even had any lesions. And then gave her Valtrex or antiviral. And you know what? It did not help.
Better.
I mean, it kind of like, good try. It was a good try right out of the gate for the first time this patient had vulvar burning. But I mean, you really have to see these lesions to diagnose this.
You make a good point because I think because this is so common and it's something we see fairly regularly, there's a lot of things on the vulva that get blamed for herpes.
Yes.
And it's not herpes, but it just goes to show you that this is like, it's just something always on our radar because we see it so often.
I've seen multiple patients that somewhere in their list of the 10 providers they've seen before me for their vulvar pain, there is often a questionable herpes diagnosis.
Yeah.
And I think it's just people looking for like an answer of like, well, there has to be some reason you're having this pain. Herpes causes pain.
And if they're looking down there, that's a win.
Yeah, oh, for sure. I'm not making fun of the people that did this. I get it. We all want an answer, but herpes is a complex scenario. All right. Well, we've mentioned already the stigma. So this is one of those things that's just so hard to get this diagnosis. And I think, one, there can be a lot of anger between partners or like, where did I get this? Questioning if there's been infidelity. And then also there's just like, what does this mean for me in the future? Like, how do I date? Do I disclose this? How do I disclose this? Will someone want to be with me? Those kinds of things. I think we both have a lot of stories about how hard this can be.
Absolutely. I mean, it just impacts your not just physically, but it's an emotional and psychological, honestly, diagnosis for a lot of people. It's a lifelong thing, and that's hard as well.
But I think it's important if you are a person who has herpes to know that this is, again, common and manageable and that you can still have a safe sexual relationship. This is not going to end your being able to have intimacy with another person. You didn't do anything wrong. I think that's like really important to say because you could have sex with one person and have this. Like, you're not doing anything wrong. You just got unlucky. And again, like I always try to bring it down. Like, these are skin sores. It feels like so much more. But really, at the end of the day, it's skin sores. I think what can be really hard, and we do need to jump at talking about these the testing, is like sometimes people can get these false results or these indeterminate results. I've had patients tell me their partner had this indeterminate HSV and they've been dating for a while, but the other person, has disclosed this indeterminate HSV and now they don't know if they're going to have sex. And so I will say that the testing on this is not perfect. And I think that's also what's so frustrating about this virus is that sometimes it's hard to know what's what with the testing. So let's talk about the best tests to use. So if you have a sore on your vulva, it is a good time for a clinician to do a PCR or a nucleic acid amplification test. These are the most accurate tests to determine if this is herpes. So if you can swab it, have it swabbed. The virus shedding changes throughout the course of the lesions changing. So if they've already scabbed over, you will have a lot less virus shedding than the very early vesicle stage or the ulceration stage. So you want to try to do it within the first, couple of days of the outbreak, or it will be much less sensitive at detecting it.
Mm-hmm.
Yeah, you guys do PCRs.
Yeah, and these are just fancy Q-tip tests, basically, that you send off to your lab. It hurts. You've got to rub it on the actual lesion, and that can really be painful, and that's hard. And in some ways, I feel bad when I have to do that. But you send it off, and essentially these are just really fancy DNA tests that are looking for the genetic material of this virus. And that is why it's so preferred, because this virus, again, it's sneaky. It's hard to get it on a culture. So that's why this is preferred.
I feel like when we were in residency, we just did viral cultures. And I think even like for the first couple of years I was out of residency, we would just do a culture. And so this is like swabbing it, and they try to grow it to confirm that's it. And this actually has fairly low sensitivity, which means it can have false negatives. And that's probably just because like there's not enough virus to continue growing. The amount of virus drops as the lesions are healing.
And that's hard. You're like, I swear to God, this is herpes. And then you tell the patient, you think this is what it is. And then you do that test and it comes back negative. And then it's just a lot of doubt on your end, on the patient's end. It's hard. So trying to really get a good solid test and get the result is important.
All right. Blood tests.
Ooh.
All right. So this is where it's a little bit crazy. We can do blood tests. There's two different kinds of blood tests. So there are immunoglobulin serology blood tests. So this is where they test IgG and IgM to see if you have antibodies to herpes type 1 or type 2. These are not as accurate as we would like them to be. I think they can be really confusing. I actually somewhat don't recommend them because I find them so confusing. And I think that they end up leaving us with a lot of times more questions than we have answers. So when we think about our immune system, when our immune system sees something new, it creates IgM antibodies. These are the first antibodies that you see. And then after a while, you'll get IgG antibodies. I always have to think about it because IgM makes me think memory, but it's the opposite.
Yeah. And Ig just stands for immunoglobulin, which is a fancy word for an antibody. And antibodies are things that your immune system will make once exposed to various bacteria, viruses, things like that. And then like once it sees it again, then it has that memory. And like, in fact, with herpes, it's like herpes, like I'm going to start creeping out of your nerve endings, and your immune system should be able to recognize that it's coming and attack and get all those things that are in your immune system to eradicate it for you. That's what these antibodies are doing. They're like little like heat-seeking missiles that just like land right into that virus when they see it again. And then it's like a tracker beam that get through all these little cells in your immune system to kill. And so that's what this is looking for. So you have an initial response of antibodies, which is IgM. And then the thing that lingers around and stays is kind of your memory for the virus is the IgG. And that's what these blood tests are looking at.
So if you looked at like serologies with an initial infection, if you looked at a graph of what these look like, you would have a big peak in IgM early, that would go down, and IgG would go up and it would stay up. And you would always have those antibodies.
You're taking me back to my immunology class in college.
I know.
It was awful.
Oh,
It's so hard. It's
like
hard. That stuff is so confusing. It's very
complicated.
Hard.
You did a great job explaining it, though, like the heat-sinking missiles. It's awesome. But so when we do these, there can be false positive results. So why does that happen? Just there can be false reactivity. Like these tests aren't perfect. It also has to do with like your pretest probability, how common it is in the population that you are looking at, like how many people in the area are positive for this. There's a lot of things that can go wrong with this test. So this is why when people come in and say, I want to get all the STI testing, I got a new partner, I want all the testing, we don't test for this. And it feels crazy. Like I get it. I was single once. Like I get it. You want to know, like, have I been exposed? Do I have this? But I always tell patients, like, if you've never had a sore, you don't really want to know because
exactly
it just becomes so complicated. This is a complicated conversation to begin with. If you say like, I have herpes, I've had sores, like this is what we can do. And, but it's even harder if you're like, I don't know, I tested positive, but I've never had a sore and I don't really know what we do now. Like, so if you've never had a sore, I do not recommend getting a test.
Yes. I'm in the exact same camp because, I'll paint the picture. Patient comes in, test me for everything, doc, test me for everything. And then I say, well, usual tests for everything for me would include HIV, hepatitis, syphilis, gonorrhea, and chlamydia. Those are done actually on either urine or a cervix swab. Those are cultures that are done at the source. Trichomonas, yeah. Also done preferred on a PCR. We'll do that sometime. I'm sure we'll talk about trichomonas, but I know they're going to want it. But I have to breach the subject to be like, okay, here's the deal. Do you really want to know if you don't have any problems? because it could be positive, and that can open an entire can of worms that we didn't ever really want to open. And these are those situations where it starts to really cause some rifts in relationships and mental distress, even just personally for people, and who and when and how and why. And we just sit there and go, I don't know.
Yeah. Yeah.
You don't.
Yeah.
And it's hard. I even had one pregnant patient. Well, she delivered, and she unfortunately had a stillbirth, which is awful and terrible. And the majority of stillbirths, we never know the reason why they happen. But when you do, you have to do a panel called a torch titer, which stands for toxoplasmosis, rubella, cytomegalovirus, and herpes. These are all infections that if someone acquires, and we'll talk about pregnancy and herpes, but that these could cause pregnancy complications, including stillbirth being one of them. And she clearly didn't have any herpes issues. And we ran the titer and it was positive. And, she was already dealing with enough horrible trauma as it was. And then we had to entertain the fact that her herpes test was positive, even though that didn't cause.
And when you say herpes test, you're talking about the IgG, right?
Correct.
Like that's so we know that there can be false positives on this.
Yeah, it was awful. I mean, you and I have delivered babies in a very, very long time. So this is a long time ago, and it still resonates with me. Like, these are the situations that are they're so hard to counsel people and work through. And it happens. It happens every day.
I can think of 2 interactions in the last year in my private practice where I've sat on a video call with like a male partner and female partner talking through these tests and what they mean and why they may not be real and who has what. And it's super complicated and it totally affects relationships.
Yep. I've seen relationships not make it over this damn test.
Yep. A skin sore.
Or a false positive blood test.
Yeah.
So like if you're in this situation, ask yourself, do I want to know?
Yeah. If you've never had a sore, don't do it.
Yeah.
Yeah. If you have sores, then we should do it so we can make sure we know what it is so we can treat it. But this is not the kind of thing that you want to screen for. The United States Preventive Task Force does not recommend screening for it. They say the harms outweigh benefits for population screening asymptomatic people.
I might actually agree with the U.S. Preventive Task Force on something there. A lot of times we don't. They're the last people to always come around to say, oh, yeah, you should get a colonoscopy at 45. Like, I don't even know if they've even come around yet on that one. But
yeah, or like the deck says at 65.
Yeah, that's them too. Yeah. Yeah.
Sorry, we digress.
Yeah.
So one thing that you can do, and this is what I do when I get into these situations where everyone's mad at each other and everyone's worried about getting it from the other partner, we'll talk about a Western blot. So Western blot is a confirmatory test. I've done some clinical trials on herpes for vaccines or herpes for new antivirals, and we always have to have a Western blot confirmatory test to actually show that the patient really has type 2 herpes. And so there's only one place in the whole country that does them. It's University of Washington here in Seattle, but you can send them from across the country through LabCorp or through your lab. They will send it here. It takes like 2 weeks to come back. I don't know what insurance coverage is for it, but it is a better test. It's looking not whether you have antibodies, but looking for actual herpes proteins in your blood that shows that you've been exposed. It is much more accurate. But again, I wouldn't screen you with this, but I sometimes will use it for like things have already hit the fan, so to speak. And like, we got to figure out what's what. So this couple can either remain together or not. And yeah. I'm like, well, why don't we just get a Western blot so we can like put this to rest?
Yeah.
Oh, it's complex. I'm getting stressed even thinking about it.
Yeah, this is why your nurse said, I will not call those back.
Yeah.
Totally fair, because it's a can of worms that you open
up. It's a can of worms. Yeah. All right, well, let's talk about transmission prevention. If you are someone who's tested positive for herpes before, you will tend to get these prodromal symptoms, like I said, before you get a lesion. So like itching or tingling. That's actually one of the times you're shedding virus the most. So you should avoid any kind of skin-to-skin contact during that time. If you are having penis and vagina sex, condoms can reduce the risk, but it's not a zero risk. You can't cover all the parts.
Yep.
And so you still could transmit it.
It was after you're done, you're the little spoon.
Yeah, the spooning.
The more you know.
Yeah. You can take antivirals. So Valtrex, valacyclovir, acyclovir, they're generic. These are good, effective antivirals that help reduce how often you get outbreaks, how much asymptomatic shedding that you have. So I do recommend these for patients if they're getting like really frequent outbreaks, just to prevent the outbreaks. But I also, if they're like in a new relationship or if their partner has never had herpes before, then I do recommend it just so that it reduces their shedding so that they're less likely to pass it on asymptomatically.
Yes, agree.
The nice thing about these medications is they generally don't have a lot of side effects. Occasionally I have somebody that says they're nauseous or has headaches from it, but like a good 99% of people don't have a lot of side effects
Yeah.
from them.
And they're cheap.
And they're cheap and they're not something that like makes you immunocompromised for other things. So they are pretty effective. So definitely if you're someone dealing with this, talking to your clinician about that, I think is good. There's a topical Zovirax, which is just topical valacyclovir, sometimes can help. Sometimes I'll get people like topical lidocaine if they have really a lot of pain, just to numb it. But ultimately, time will make these get better.
That and pee in the bathtub if you can't pee.
Yeah, if you can't pee in the bathtub.
It helps.
Yeah, it's just like that urine hitting on the vulva can make it painful. Anything we want to say about dating and disclosure?
That's the next question we always get is what do I tell my partners? And you're my partner now or my partners in the future. Yeah, I mean, it's really hard.
I don't know if I have any specific things. I always think being honest and upfront about it is good. I think it's hard, but I think it's important for disclosure purposes, for trust purposes, for those kinds of things. I think it is important to have these conversations.
Especially if, you become symptomatic and now you have to try to avoid, if you haven't disclosed, like it just, there's a lot of scenarios that you have to kind of think through.
Yeah. So I would say have a conversation about it. Be honest about it. Yeah, I validate it. It's not easy. It's super hard.
Special scenarios, pregnancy.
Mm-hmm.
We don't talk about that very much on Labia Logic.
We don't. Maybe we should. Maybe we should do an episode on pregnancy in your vulva.
Maybe we can.
Because things change down there.
Sure, yes, they do. They have to. But this is a very special scenario in that herpes can be transmitted to an infant, not during the pregnancy. As people become infected, or have an outbreak while pregnant, not concerning for the fetus. It's more the actual birth. Again, this is transmitted through contact. So it would require a baby being born out of the vagina to come into contact with the virus in order to cause transmission. So that's the biggest concern. And Ashley and I've been part of many exams. Patient comes in labor and has a history of genital herpes, and you have to look and make sure you don't see anything and ask the patient, do you feel like you're going to have anything? Because if they do have lesions or they have the prodrome, then we perform a C-section in order to avoid any contact to the baby. These patients typically always will also start antiviral treatments at around 36 weeks, which in pregnancy talk is about 4 weeks before your due date of 40 weeks. And that's typically, when we start kind of assessing and looking like, might you go into labor sometime soon? It's when you start seeing your doctor every single week. You're getting your cervix checked and all that fun stuff. And so there's a reason you start going every week is because we're starting to go, is the baby coming anytime soon? So of course, if there's concern and you have a history of genital herpes, we're going to want to do everything we can to suppress and not let an infection happen or outbreak happen. So that is generally the consensus that we do. I've seen scenarios, I know you probably have too, where maybe they had an outbreak like on their thigh, and like you kind of can have that conversation with the patients. And I've seen it before where we put tape over the lesions.
Yeah, you can do that. That's like board question. You can totally do that. Babies can die from this. So like I also think it's reasonable to say if you have an outbreak anywhere in your body that it not anywhere but I've done anywhere that a baby could touch that it's reasonable to offer a C-section because this is not something you want to play with. Babies can die. Newborns that they get exposed to herpes, their immune system has no way to fight it.
Yeah.
All right. Yeah. If you have had a herpes outbreak before and you're pregnant, you just need to make sure your OBGYN knows, your obstetrician probably does know. They will talk to you about it. They will offer you antivirals at 36 weeks and make sure that you don't have an outbreak around the time of delivery.
But even in pregnancy, like we talked about screening people and like just check me for everything, we don't screen for herpes in pregnancy.
No.
We screen for HIV and hepatitis and syphilis and things like that, but we do not screen for herpes.
We talked about antivirals and we talked about you can just take them just as needed for an outbreak, episodic we call it, or you could take them all the time to suppress. And then we talked about some of the other things that you can use to help with pain, like topical lidocaine, baths, those kinds of things. There is a new drug. I was actually involved in the clinical trials for this, a company called Assembly Bio out of the Bay Area. has a new antiviral, and it is a long-lasting antiviral. So they just finished their phase 1 and had just published their data a couple weeks ago. And it's actually kind of exciting. So it's weekly dosing orally, so only once a week, which is actually really nice. It has a pretty long half-life. And they showed 98% reduction in HSV-2 shedding versus placebo, which is super exciting. I've been involved in some clinical trials in the last 2 years looking at herpes vaccines, and they've not done well. Again, this virus is just super hard to find the right target for, but I do hope for a day that we could find a herpes vaccine. Again, herpes doesn't kill immunocompetent people. It can kill newborns, like we talked about, but there's so much stigma around it and it affects so many people that I think that it would be amazing to have a vaccine for it and or a better treatment to help reduce the shedding. Because I think that's one of the biggest things is like the idea of passing it on.
Yeah. I mean, you talk about the serious infections in like infants and in immunocompromised people. This is encephalitis. It will cause a brain infection. And I have taken care of immunocompromised people in the ICU, and it's really, really awful.
Yeah. So anyway, super exciting that we have this, phase 1 data. Phase 1 means it's the first time it's been in humans. So we still have a long way to go on this. So they'll have to do phase 2 and phase 3 trials. So this is many years away still, but it's very exciting that at least something is working because, again, this virus evades the immune system so adeptly that it's nice to have some good options. All right. So we're going to do a little misconceptions about herpes lightning round.
Love it.
All right. If I don't have sores, I can't transmit. True or false?
That would be false.
False. We talked about that. If you don't have a sore, you can shed asymptomatically, and there's no way for you to know whether you're shedding or not. Somebody who, if they're worried about that, or if they have a partner that doesn't have herpes, that would be going on an antiviral might be good to help reduce that shedding.
Next, HSV-1 is harmless. HSV-2 is worse.
HSV-1 is not harmless. Like I mentioned, it is generally oral, but it can be genital. It tends to have less recurrence and be less painful when you have it. And there's some data that after 1 year, you actually have way less asymptomatic shedding with HSV-1. So I would say it's better, but still not ideal.
Yeah.
HSV-2 tends to be more shedding, more painful outbreaks, and more recurrence. All right, blood test positive means I definitely have genital herpes.
If you're not seeing us on YouTube, you need to know that both of us cringe at this question because it's so hard. I think we all know the answer to this.
Right. So blood tests aren't always perfect. They can react with other proteins and be wrong, and it's confusing. And just unless you have a sore, don't do it.
Yeah.
You can't have a normal sex life if you have herpes.
False. Absolutely false.
Totally false. You can. I think consent, disclosure, antivirals, being aware of your symptoms, condoms, there's a lot of options here. So I just definitely think that there are ways to still have a good normal sex life. I just think that there's more things to think about, but I definitely think it's possible.
Yes. And condoms make it impossible to transmit the herpes virus.
Not true. Think about the little spoon.
Little spoon.
So you can totally still get herpes with a condom, although it does reduce the risk. It does not make it zero.
Yep.
And our last one, we're both cringing as we're trying. I don't know if I can say it. Everyone should be screened for herpes.
Hell no.
Hell no. No, don't do it. Don't do it. Don't do it. Harm outweighs the benefits. If you don't have a sore, don't do a blood test. That's my tagline.
Agree.
All right. Well, I think we did it. We appreciate you being here to talk about herpes. I know it's not the most exciting thing to talk about, but it is a reality of a lot of people's lives. Something we see all the time. I think it's important to know about. If you're liking our content, we appreciate it. Leave us a like or a comment on Spotify or Apple Podcasts, wherever you hear us on podcast or YouTube. And if there's something you want us to talk about that we haven't talked about, let us know. We're always happy to look at new things. We have a lot of things in store for you still this year, but if you have things that you feel like we've missed or you want more information on, please let us know. Thanks for joining us for this episode of Labia Logic.
We get it. Sharing a podcast like this might feel a little taboo, but we're here to break down those barriers. Labia Logic's all about empowerment, not embarrassment.
If you found this episode helpful, we hope you share it with others who could use a little labia logic in their lives. Can't we all? You can find us on all major podcast platforms and connect with us on Instagram at labia_logic.
From our lips to yours,
Viva la vulva!